Cast is now starting. All attendees are in listen-only mode.
Good afternoon, my friends, and welcome to today's webinar. We have just about one more minute for folks to join, and we've got a pretty robust group today that will be joining us. About 150 plus folks have actually signed up for this webinar, this part three in a series of three webinars on how to improve your revenue cycle results. So if I can ask for your patience and your tolerance for just one more minute as we give folks just an opportunity to join us. And I know a lot of folks are coming off of lunch, so I appreciate you taking the time to spend some time with us. Okay, we're just about 1 minute after 1. We can go ahead and get started as folks are joining. Good afternoon. My name is Bart Gregg. I'm a Director of Operations with Azalea Health in Atlanta, Georgia. I'm happy to be joining you today in, as I said, part 3 of a 3-part webinar series on enhancing your revenue cycle performance. Today we'll be going over some benchmarking, some KPIs. The first 2 series that we had talked about KPIs, I believe in series 1, and in series 2 we talked about appeals and denials. So we're kind of tying the bow on everything today. And presenting today is one of the founding members of Azalea Health and the Vice President of Revenue Cycle Management, Doug Swords. I know that there may very well be some great questions that we're looking forward to answering. So what I would ask is in the chat function, put in any questions that you may have. And at the end of our presentation, we'll be sure to answer every single one. That said, I give you Doug Swords. And Doug, thank you for joining us this afternoon.
Thank you, Bart. Can you confirm that you can hear me and see my screen okay?
Yes, sir.
All right. Well, welcome, everybody. I'm Doug Swords. Like Bart mentioned, I'm a co-founder and vice president of revenue cycle management with Azalea Health. We are a healthcare technology firm who also provides revenue cycle management services. And I'm here today to kind of share some of the best practices on reporting, KPIs, and benchmarking that we've used to serve our clients and to help manage our organization. So I'm originally from Atlanta and moved to South Georgia to go to Valdosta State University. I have been in revenue cycle management since 2003 and have helped, started out in the laboratory industry and have been through physician, small, large, specialty, surgical. My whole career since college has been in revenue cycle management. And so hopefully I'll be able to share some stuff with you guys today that you can take back with you. I'm going to start by setting the stage and kind of giving you some background where we've come from over the last couple of years. Some of these are some trends that we're seeing that have started started several years ago, but I'll start with the 2019 survey that we conducted. And this, I think, holds true even today, where the top challenges that organizations are facing, which is one of the reasons why we're having these webinars, is to kind of give you some feedback and some helpful tips on how you can address these issues like declining reimbursements, having understaffed or maybe not qualified staff. Turnover is a big thing now this year that everybody's experiencing, and also trying to improve these processes. And those were kind of the top 3, even when you're talking about marketing and attracting new patients, and your healthcare IT needs and technology. It seemed like reimbursement hit the top as far as like organizational needs and pain points. Fast forward to 2020, last year, and we had the COVID pandemic, and that had its own set of hardships that we had to deal with. So we had, immediate decline in patient volumes as folks stayed home, they sheltered in place. As we scrambled to get people seen through telehealth and other new technologies that we had to learn, we also had to learn new billing requirements that were coming out, and guidelines and things which were actually helpful were being loosened for us in order to do more with telehealth, for example. But it was also very confusing. You had Medicare, you had Medicaid, state-specific guidelines, you had the commercial payers handling things a little bit differently. And we lost money during this period. People got laid off, people got furloughed, practices got closed, hospitals got closed. So it was a big, major financial impact that we're still recovering from today. And this is just an illustration of the cumulative visit deficit that, depending on your specialty, that we experienced. And these visits just never came back. There was no rubber band effect of visits. We had just folks staying away and dealing with things at home. And so we lost a lot of money during this time period. So one of the takeaways from that and the positives was that we learned a lot, and we grew as leaders and as organizations. And this is just a list of some of the regulatory changes that, and some of these have carried over to today. The emergency, the emergency period continues to be extended. You got your federal, and then you've got your state level. And so we still have, and I remember at Azalea, and I know a lot of practices did this too, trying to keep up with the list of regulatory changes, especially when it comes to telehealth and COVID vaccines, COVID testing and codes and reimbursement guidelines that we had to keep up with per payer. And so what happened? Not only was it bad as far as we lost money, but you could say the silver lining to all of that is we really had some positive impacts. We got, as Walt Disney's quote said, we had some adversity. We got kicked in the teeth, but it was good for us because we were able to become, as I mentioned, better leaders. We had to make tough decisions on cost controls. We had to implement new processes and procedures, new workflows. If you're a medical organization, you had to start routing people differently and triaging people in parking lots. We had to learn and adopt new technology. Telehealth is a main one. Patient portals became much more highly utilized, and we had to kind of take a deeper dive into our analytics, which is part of what we're going to be talking about today is, we lost all those visits, and now let's focus on the money that we have control of. Where is our AR? Where are our payments? Let's squeeze every dollar out of what we can, and let's learn as much as we can about coding and reimbursement and patient engagement. How do we keep our patients from going elsewhere? How do we keep them engaged if we can't speak to them? And that has all carried over to today. So the other big trend that kind of sets the stage for the rest of this, and this has been part of my other two, if you've seen the first two in the series on front end best practices and back end, the front end in particular, we're talking a lot about collecting from patients and patient responsibility and how, high deductible health plans are the norm these days, and you have more patient financial accountability, and how does that affect the way we process our revenue cycle? And every year I kind of update these numbers, but last year 27% of all the Azalea collections from Azalea clients and their patient came from patients. 27% came from the patient directly, 73% from the payer. And I remember starting out early 2000s, and even when, in the late 2000s, when we were getting Azalea going, maybe 5 or 10% would be the amount that a practice could, collect from a patient. It's completely changed, and we have to make sure that we're considering that with our decision making. This is just some additional information. 32% of American workers, according to a poll of large employers, have some form of medical debt. And if you look at that graph on the right, of those that do have medical debt, it's, generally over $1,000 or more. $1,500 to $5,000 is, upwards of 10,000 is the majority. So, that comes with, not being able to communicate with the patient effectively, not having, effective collection practices up front, not asking for the money. And I would highly recommend, and it's not on our website yet, but the entire series will be available on our webinars page, that best practices on front end. I go over that, just how to redefine your workflows up front. How do you maximize your collections from your patients? So definitely go back and look for that. So the big themes of all of these enhancing your revenue cycle webinars have been, let's revisit, let's deconstruct our processes and let's reevaluate them. Let's redesign them. Let's figure out, after we've redesigned, how do we reallocate resources? And this is true with any change, of any organizational change, not just revenue cycle, but this is definitely how I would recommend and we should all be revisiting our processes, on a regular basis to make sure, like, how are things being done now? Where are inefficiencies? What can be changed? What resources does that take? How do we deploy? So that will be part of today's presentation as well. And then again, how do we get, when we do make changes, a big part of what we're going to try to do is get more out of our software. How do we get more data? How do we analyze the data? How do we automate the software? And so a lot of times you'll hear webinars and you'll see things about artificial intelligence, machine learning, and the simplified version is how do we maximize the features, the tools that we have available to us to make ourselves more automated and more intelligent and make better decisions. And then finally, the only way to really track if what we're doing is successful is to benchmark. So again, that is a big part of our discussion today is what are good benchmarks? What's a good key performance indicator? What does it mean? How is it calculated? And what is our number? And then how does that stack up? How does it stack up against others in the industry? And so we'll talk about that today. And as a matter of fact, here's a few numbers that, that are like industry MGMA kind of averages where you could compare yourself. So the outcomes of today, I kind of mentioned these. We're going to talk about calculating, interpreting key performance indicators, using benchmarking to track your own performance, and then using data to analyze and find negative trends and perform root cause analysis. So it's one thing to find out that you're maybe not doing a great job, but then the next piece is, well, how do I investigate this? How do we dig in and find out what the problems are and how do we solve them? And again, this today, you could be the intended audience for this is a physician's office, could be a one doc practice, could be a large medical organization. You could also be an RCM company like Azalea. So a lot of this is for, all of the above. And so I'll kind of touch on all of it a little bit. And kind of taking a step back, Azalea has recently acquired Dashboard MD, and we rely on that tool. We call it Azalea Insights heavily to perform analytics. And I know sometimes it is not easy if you don't have a good analytics tool to do this. So I'm actually going to give you some examples of how you could build your own dashboards and things without having a tool that automates it for you. But I'm going to talk about weekly leading indicators, or basically leading indicators, lagging indicators. And we're going to talk about annual reporting, monthly reporting, and we're going to be looking at turnaround time on claims, denial rates, and I'm going to start by talking about leading indicators. So this is probably one of the least common used KPIs, but we love it and we use it a lot at Azalea to track just internally things at a routine cadence so we can see if we're getting out of alignment. Because what will happen if you don't have some sort of leading indicators, you're going to wait till the end of the month, for example, to run reports. You may find out that we haven't collected as much money this month, or maybe not enough claims have been filed, or we're behind on something where the purpose of a leading indicator is to track data at set intervals and get ahead of it. So for example, and I would definitely recommend to keep it very simple. You start with claims that have been sent out and how much revenue has been collected, deposited, and recorded at the same cadence. You could do it every week, or you could do it, okay, I'm going to do it on the 10th, the 15th, the 20th of every month, that sort of thing, and then compare to previous months. So if you're looking at this graph, for example, and you look at November 10th, we had collected $128,000 and filed 655 claims. Now, if you go back a month, it's actually dropped from October. So what does that mean? It means, well, we filed less claims and we've actually collected less money. So that way I know that, okay, we're off pace a little bit. And so at the end of October, we had over 265,000. If I'm now asked as a forecast by the provider or the administrator, well, hey, what's November looking like? I could actually give them some sort of idea. Well, we're off X% from October, and we can expect to make this much by the end of the month if that holds true. It's a good way to predict and forecast in the future. Now, also, you could take a look at this and say, well, what if we're way off? Like look at September versus October on the 10th. We had filed 100 more claims during that time period, but we had actually, the collections weren't the same. So it also allows us to say, well, are we falling behind? Especially if you see a drastic change from the same time periods. It allows you to take action quickly and not wait. So if you're looking at your numbers monthly or quarterly, by then it may be too late to make a change, and you may be looking at lost revenue. So I would also recommend, if you don't have access to an analytics tool, or if you have just a very specific set of KPIs that you want to track, to build your own dashboard. And we like this one. This is actually a 13 months. You'll see it's got October of the current year and October of last year and the 12 months leading up to this month. And we're actually able to trend things over time. So this is great because you can see seasonality effects, especially if you have deductibles, which we all do at the beginning of the year, that kick in, and maybe your revenue and charges might drop at the beginning of the year because of that. And you want to maybe see it all in one place. This allows me to see gross charges. How much have I written off? How much have I collected? How much was collected at point of service? What's my total AR? What's my days in AR? And I actually have the calculation there in Excel. If you wanted to do the 12-month formula, you could also do a 90-day formula and divide by 90 instead of 365. And then your sum column there would just be for 3 months instead of 12. And then you could also see average days to bill, which is the time between the date of service and the initial bill date. The payment rate, visit count. We really like payments per visit and patient payment per visit too, which we'll get into. And we actually talked about that, especially patient payment per visit in the first webinar on front-end best practices, because it gives us a gauge of how much are we collecting per patient and how is that trending. So we'll talk about that a little bit more too. But this, depending on what you want to see, it gives you a lot of information in one place and allows you to kind of see from a high level. This also really is helpful if you're needing something to report to a board or to a C-suite or to your doctor, if the doctor is the main managing partner of the practice. And so that's what this looks like. And again, it allows you to look for negative trends and outliers. Once you build this out, it's just a matter of updating it once a month, and then you could build formulas in here to track for things. And again, if something gets out of line, you have another 12 months to compare it to. So you can say, well, this is the best it's been in the last year, or this is the worst that it's been and why. So the next step I would take with this, and this is for those of you who maybe have multiple locations, if you're a billing company, maybe you have multiple clients, or if you're a larger organization, you have multiple locations and providers. So if you do have on the previous slide, maybe days in AR is getting out of control, or your average days to bill has spiked, the next thing you want to do is kind of break things down by location, by provider, to see if there's a particular provider that is maybe causing it, or maybe staff at a certain location that is slowing things down. So in this example, if you looked at Dr. Jones by provider, his average days to bill is 11. And so that may be what's bringing the average up for the month. And so then the other ones are great, the 2 or 3 days. So what's the holdup with Dr. Jones? Is he taking too long to code? Is the staff taking too long to finalize his visits and coding? Is he at a specific location, possibly like location number 6 or 7 on here, that the staff there is just taking longer than usual to get claims processed and out the door? And if so, why? And then that's where to focus your efforts. So let's turn around then and break these KPIs down by the revenue cycle, starting with the front end, point of service collections and claims benchmarks. Here are 3 calculations and benchmarks that we like to track. You have your EDI rejection rate, average days to bill, and point of service collection percentage. Now, this is not everything. I could go on probably about 2 or 3 hours, and there's probably benchmarks that maybe you like better or that others would recommend. But these are 3 that we like that help you kind of understand your efficiency on the front end. And so you talk about EDI rejection rate and your average days to bill kind of go together, in that your goal is to send claims as quickly as you can because you want to keep the cash flow coming. So that's where the average days to bill, you want to get those out the door, less than 8 days if you can. The industry standard is about 10 days. And a lot of times if you go to your clearinghouse and the clearinghouse dashboard, if you log in, they'll many times, and I know TriZetto, we use them a lot, they'll have a dashboard where they'll say, well, our client's system-wide average days to bill is this, and here's where you rank. And so a lot of these can. And same as the EDI rejection rate, a lot of times if you want to see how you stack up, you could go to your clearinghouse and see what that looks like. But we do recommend that your initial rejection rate, meaning when you file claims, how many of them are being rejected at the clearinghouse level, you need that to be less than 4%. So the goal then is not to just file a bunch of claims out sloppy to get them out the door. You want them to be out cleanly and quickly. And so those two benchmarks kind of go together for that reason. And I've got the calculation listed at the bottom. The point of service collection, I've thrown that one in recently because, again, we talked about how more and more money needs to be collected from the patient. They owe more now, and a lot of times they're on high deductible health plans, and they have payments that they, in many cases, especially at the beginning of the year, they need to pay in full at the time of service, or you can end up having to bill them on the back end, which makes it much more difficult to collect. And the point of service collection percentage kind of gives you an idea of how efficient your front end collections are as a percentage of total patient collections. So the goal is to collect as much up front, if you can, as possible, and not rely on waiting on back end invoicing. Because then even if you do have a really good, robust invoicing, text to pay, patient portal, you're still odds of collecting drop tremendously. So time of service collections, again, this is going back to that 13-month model. If you do track patient payment per visit, you're kind of able to see that if it's getting better or worse. And if you compare that with that point of service collections percentage, you can really track the effectiveness of your front end collections overall. And it may, going back to the slide earlier, you may want to revisit your process, break it down, analyze it. How are we determining patient out-of-pocket amounts? How are we asking for payments? How is the whole process working now? Is it effective? Do we need to make tweaks and changes to it, retrain the staff on what our expectations are for collections at the front end? Because again, depending on your specialty, we're talking 20 to 40% of your collections, comes from the patient. And if we don't have a really good process up front to collect that money, then, we're going to struggle, and it's going to be a big impact on our bottom line. So I've got some things kind of bolded with a red outline, which would kind of be your outliers that you would want to look at, especially if you're trending things over time. So in this one, we appear to be actually getting better at patient payments per visit. So that would be kind of a justification for maybe any new processes we implemented, or maybe certain employees are doing a better job of collecting up front. You can see back in March, our patient payment percentage as a total dropped, and that maybe we may want to discuss, especially if this was that month, what happened? Why are we collecting less? Did we, stop asking for payments that month? What happened to make our patient payment collection rate drop so much? And then time of service patient payments as a percentage, again, we're tracking that here. Goal is to be, as I mentioned before, greater than 70%. So we're still not there yet. So what's great about this, though, is it shows we're making improvements, but that we're still not quite where we need to be. But it at least gives us something to hang our hats on. So the next step on this is average days to file a claim. So, you want to collect that money up front. You want to get these claims out the door quickly, and you want them to get out cleanly, because, it takes that much more time to fix a rejection, to get it refiled, delays your ability to collect on those claims. So we do recommend something less than 8 days. And again, I mentioned this before, but if you can break this down by location or by provider, especially if you see your overall average days to bill going up, then that's where you can kind of try to figure out, well, what is the bottleneck here? If it is, multiple locations and there's an issue with that. Again, it's in the formula is listed here. The average length of days between the date of service and the initial bill date for claims filed in a given time period, or in a given month, if you're going to go with this breakdown. And then you can also search clearinghouse and your vendor, your PM EHR vendor for reports. So they may already have this information for you. And again, if you wanted to carry it over onto a spreadsheet or just pull it from your clearinghouse directly, you can. But for the most part, they should be able to share with you your average days to bill if you don't have a report in your PM system that makes it easy to calculate. Another one that's important, this is part of the Rural Health Clinic boot camp series that we did last year, is, how efficient are we at scheduling, and what is our availability, and what is our utilization rates? So this one is a bit more involved, but if you have, this one came from our analytics tool with Dashboard MD, but it basically takes all the appointments for a given period of time, and we break them down. How many folks arrived? How many folks didn't show up? How many folks rescheduled? And that which is bumped on this. and what is that as a percent? And for this to work, the staff really has to be using your scheduling system correctly, meaning that they're checking in people appropriately, that they're effectively flagging folks that don't show up and all that, so that way the stats will pull correctly. And then when you take it down to the bottom, how many business days are there in the month? How many open time slots, or how many available time slots were there on their schedule? How many of them were actually filled? What that percentage looked like. So that way too, if you're a growing practice and you're trying to figure out like how many more patients could we possibly take before we need to hire another provider, for example, or are we doing something inefficiently where we're not filling our time slots appropriately? This is very helpful for that. And again, it's all in one place. Especially too, like if you go back up to the top, you're going to watch for your trends on, your rescheduled, your canceled, your no-shows. So that way too, if things are getting worse over time, you want to take direct action. This allows you to see that. A free tool that I wanted to throw in here, especially when it comes to this, is again front end, the E&M analysis and bell curve. So this is part of the coding KPIs. So a lot of you, may be interested to see, well, am I overcoding or am I undercoding? And this tool, and there is, if you just Google that, the AAPC free E&M bell curve analysis tool allows you to pick your specialty. And then if you want to run a report out of your own system, you can plug in your numbers. For this one is for a 12-month period, but I think you could even put in, if you wanted to run it for a shorter period of time, you can, but plug in your numbers here. And then when you calculate, it's going to kind of tell you how you stack up. And this is also a great way to benchmark your E&M coding. And this is something you could do like once a year, for example, or every 6 months, to see if there is potentially a problem. And again, if there is, if we decide that, our actual level 3 coding is higher than the national average or lower, then we want to kind of maybe take a look at auditing some of the documentation to decide, okay, are we really, is the documentation backing up the levels, or are we undercoding, or are we overcoding? And then that would allow you to give the feedback to the providers as well. And this would give you something tangible that you could point at too when you are approaching your providers or whoever it is that does the coding, to make sure that they understand where this is coming from. This is not just my opinion, but this is, you may be looking at an audit, for example, if our actual usage of a level 4 is way higher than the national average, then you could be on deck for an audit, for example. And this could be a way to get ahead of that. Conversely, too, if you're undercoding, and this would be a way for you to catch that as well. So if you realize that your docs are heavily using level 2s when they could, based on documentation, qualify for level 3 or 4, that's some training. But this gives you, the background for that, so that way you can move forward with maybe some additional training and optimizing your EHR too. So if there's something with your templates that could be maximized, that maybe a template is being used incorrectly and it's only qualifying you for a level 2, that's something you can look at. So continuing down the path of the revenue cycle, the next is your back-end denials and AR follow-up benchmarks. So here's 4. Again, there's way more than this, but these are kind of 4 good ones that we recommend that, if you're just starting today, for example, that you could go with these, and, fairly simple to calculate. You've got your denial rate, which is not the same as your EDI rejection rate. These are claims that did get to the payer. They did not get rejected, but once they got to the payer, they were denied. And, the denial could be for non-covered service. It could be for any number of reasons, but they did not pay the claim. And the way it's calculated is you take how much in dollars were denied. So if the whole claim was denied or a certain CPT line, and then you divide that into the total number of claims charges filed for the same time period. And you want to be less than 5% if you can. That is the best practices. We see most folks are somewhere around 10%. 5 to 10%, and especially if it gets over 10%, there's a problem that you want to kind of look into. But it's basically telling you, like, for every dollar that you send to a payer, how much of that is getting denied. And, because we know how expensive denials can be to rework. And if you go back and look for my second best practices webinar on the back end, I go in a lot of detail about how much does it cost to work denials, what effect does that have on your ability to collect. So you really want to kind of look at that and track your denial rate over time. Days in AR, Again, I gave you a formula on a previous slide to calculate that, but it basically indicates your overall, it's probably your number one indicator if you want to kind of say, well, if I could only use one benchmark to track the effectiveness of my revenue cycle processes, it would be days in AR. And you want to be less than 40 if you can. Best practices would have you in the 20s, but if you're less than 40, that's pretty healthy. According to MGMA, depending on your specialty, we're looking at, 50 to 60 days in AR or higher. And that takes the whole thing into regard, like your days in AR, how quickly are you flipping over your AR compared to how much you're billing out each month. So then we also look at your aging buckets. So you can really do this several different ways, but we like to look at that initial bucket, which we would consider current. So your 0 to 60. We want your AR, if you were to add all that up in those two buckets, to be 80% or higher. But then if you also took it all the way to the back end, you say, well, the older your AR gets, the more likely it is to not be paid and to become untimely. You want to kind of have less than 12%, if you can, in that bucket of your total AR. Now, this is total AR, so it includes your patients who haven't paid their bills and insurance payers that haven't paid. You could break it out as well and look at it insurance versus patient, and we'll talk about that too. But there's other KPIs too that look at things 90 days and up and not just 120. But again, if you can break down your AR stats by bucket like this, and I'll give you kind of a visual representation to look at, and then track the percentages, set your benchmarks too, then that way your team knows what they're being graded on, and then you can also compare yourself to industry standards and against your own performance. Here's an example of an actual report. This came from our analytics tool to give you an idea of how you could calculate your denials percentage. There's two ways. We generally like using the dollar amount, like I said. So how many dollars of denied charges do we have in a certain time period, and how many total billed charges do we have in a certain time period, and then just do a percent. Now you could also do count, so the number of claims. And if you have the ability to do both just to see how different they are, I would recommend it. And this is a report that automatically calculates it for us and trends it for us over time. But you could easily build this in a spreadsheet as well, where you put the total denied charges, the count of denied charges, and then again, total charges, total count of billed charges, and then do your percentages. The next thing to do, so even if your number is great, or if your denial percentage is not great, you want to kind of break it down by type. And your clearinghouse, a lot of times, will have this for you. And a lot of times your PM system will have a denials analysis report. So you don't necessarily have to build one, but we would recommend that you break it down kind of by category. So if you are struggling, or even if your number is good, but it's slowly getting worse, your denial percentage, you want to kind of figure out where is the problem. And this again goes to the root cause analysis. So, you can look at charges or the claim number. That's the difference between the chart on the left and the right. That way, if there's a big difference, but the charges is your total dollars denied versus number of claims. And you can see here, a lot of these are benefit level. So maybe we got some non-covered services, or some services that are being billed that are part of a global period, or just non-covered. And we may want to kind of look at that to see, are we providing services that aren't going to get paid? Are we aware of it? Should we have collected that from the patient up front? Are we not checking benefits, prior to the service? Is there an issue with our eligibility and benefits process? The back-end payer edits, what are those? If there's so many, what is the payer edit? Or is there a specific payer that is triggering these, or what are we looking at? So if it is like system-wide, or is it a certain payer that we're getting those edits from? And then if the other categories are bigger, like prior auth, then you may have a problem with your prior auth process. Eligibility, coordination of benefits is maybe we're not fully collecting the patient's insurance information, primary, secondary. Maybe we're not verifying if they have a Medicare Advantage plan that's taken place of regular Medicare, or a Medicaid CMO plan, or maybe we've got them flipped in the system, and coordination of benefits is an issue then, and that could be a front-end registration problem. So definitely check your denials by type. And then you also want to look at your denials by insurance class. So again, if you do decide, or you do see, wow, we have a problem with payer edits, But then if you could see the denials broken down by type, and if you see, a higher percentage coming from Medicare, then you'll know where to focus your efforts, and you can see what is going on. Do we have an LCD and NCD issue? Do we need to do some more training? Is there a problem with the templates in our software? Coding issues. What is it that is creating these issues, and allows you to kind of dig in? So in summary, you want to look at your denial percentages. You want to break that down if you can by type, by charges, by claim, and then also if you can break it down by insurance class. So continuing on, your AR management, I really recommend that you build, if you can, a spreadsheet or be able to run a report that can show you where your money sits at a set time, preferably like the first or maybe the last day of every month. So that way you can see what your total AR and then what the AR looks like in each bucket every month. So you can sit there and eyeball it and trend it over time. And then if you see over on the right, I've got my percentages. So how much of my money is in the 0 to 30 as a percentage of total AR. And again, I mentioned earlier, if you take those first two buckets, the 0 to 30, 31 to 60, and add them up, you want that to be 80% or higher. And then again, on the back end, the 121, you want that to be less than 12% if you can. But, as you can see on this example, even though we're maybe 10% is less than 12, you can see trending in the wrong direction, and our dollars in the 121 plus bucket is increasing. Now, you could also look at this in terms of number of claims too, or dollars. You can do both. If you can get both, that's great too, because sometimes you may have actually a claim issue, smaller dollar amounts, but you may also be more inclined to go after the larger dollar amounts. So for this example, if you had to pick one, I would go with dollar amounts, but you're looking for outliers here. So you're looking for and that's why I have them with the red font on the border, like especially back in June, we had a bunch of money in May and June slip into the 31 to 60 bucket. And so if I were looking at this in real time, like say this was May or June, I would say, okay, why historically we've had 50 something thousand in that bucket. Why all of a sudden it's at 100,000? And a lot of times what we'll find is a batch of claims went missing, or a certain number of days worth of claims maybe was never keyed into the system, or things got to the clearinghouse and the clearinghouse never sent the files. And you'll find like a whole set of claims or a whole batch, or maybe you just got a whole ton of denials from a certain payer for a certain claim type. But something big happened to a big set of claims that caused them to roll. And it's generally one of those types of situations where we forgot to file claims for a certain number of days. A claim file went missing. Clearinghouse didn't send the claims. But the only way to really check that is to look at it like this at these intervals. So that way, if you do see a big shift like that between buckets, you can immediately take action before it's too late. So then that was total aging, but then if you can, break it down your insurance and patient. So with the patient aging, and I've got some kind of recommendations here on your percentages for your buckets. We talked about your insurance aging and why you would be looking for those outliers, and you're looking for chunks of claims or where to target your efforts, as far as like working your aging and maybe finding problems, root causes. But with your patient aging too, you want to keep track of that. So if your patients aren't paying their bills, do we have an effective collections process on the back end? And if we don't, we need to revisit that process. Are we sending people to collections? What is our policy there? A lot of times we find collections fall by the wayside because we get busy, and if it comes between posting payments and filing claims, processing patient balances to go to a collection agency or being written off is kind of one of the last things to do. But if you don't track it like this and split it out, you'll find some big problems are going to start creeping up. You're going to be wasting time sending statements. You're going to find that your cost of sending, if you're still mailing statements, is going through the roof. You're also enabling your patients by allowing them to, not pay their bills. So you want to kind of watch those separately. That's why it's important to break out your patient aging and your insurance aging too. And then also see it as a combined effort. Of course, you want to break down so if you're talking about insurance aging, you want to break it down by class. So going back here, if you do decide, well, hey, I'm spiking in my 121 plus bucket for insurance. Historically, it's been 20-something thousand dollars in that bucket. Now we're up over 50,000, in the upper 40,000. So let's break it down by class and see what that is. And you may find it's a certain payer or a couple of payers that are causing it. And so this is that root cause analysis that we talked about before. If you do break it down by class, that would be the next step that I would recommend after you identify that your aging isn't where you want it to be. And you find out, well, is it Medicare? Is it if it's commercial, are there certain payers in that bucket? Is it United Healthcare? What is it? But it allows you to kind of focus in so you're not just flailing around and running a full aging report and just not having a plan or a strategy. And if it's like in this example, you have your Medicare Advantage, there's something going on there. And we want to figure out, well, is that money still sitting there? Are we getting a certain number of denials that are repetitive and that we're just not fixing? Or maybe our people don't know how to fix them and we need to do some more training. A report that we recommend is just matched AR. So this is basically a visual representation of every dollar that was filed in a certain month and whether it was paid, adjusted, or still sitting there on the AR. So in this example, if you go back to like May 2020, everything's been accounted for in that month. It's either been paid or written off. There's nothing left. But then if you go to June and July of 2020, you'll see there's still a little bit of money, especially if you go down there at the bottom and look, that has not been collected yet. And so the red represents AR for service dates in that month that has not yet been collected. And it's a good way for you to see the older the bars, the further away they are with the red, the less likely you are to collect on that. This also allows you to kind of calculate, your percentage, if you want to take it a step further, of collections, but matched, and this is called matched AR dollars. Here's another report that we like. And when we're talking about reporting, different ways to look at it is great. So we want to not always just be looking at our data in terms of a snapshot in time. We always want to be comparing it. So I already showed you like a 12 and a 13 month like analysis. This one is great because it looks at what you did for a certain month and compares it to a 6-month average, which is fantastic. And on the same report, it tells you, well, what did you do during the same month last year? And so, and with the variance. And this has pre-calculated KPIs in it. Again, this came from an analytics tool. You may be able to get something like this from your current vendor or from an analytics tool. But what this does is it saves me time because I don't have to build my own report, but it does have a lot of useful KPIs already built onto it. This one looks great. I can hand it to an executive. I can hand it to my board. I can hand it to the doctor, administrator, and it really tells a lot. This is actually part of a 4-page complete provider analysis report, but this is just the first page of it. And I just like that concept of comparing to a 6-month average and then comparing to the same period last year. This is another kind of a canned report. It's a little different, but it's also a 12-month, but it gives you the ability to trend things over time, including like gross versus your net. So I would also recommend for collection rates, if you can isolate your contractual adjustments, you can figure out what your gross and net. So for net, your goal is to be at 100, meaning, hopefully no claims denied, you get everything paid, and what was not paid was just simply a contractual adjustment. That is your net collection rate. Gross is just purely comparing what were you paid versus what did you bill. Those are both beneficial to track over time. Because the higher your gross collection rate, you may, say your gross collection rate is like, 60, 70%. You may think that's great, but it also could be an indicator that your fee schedules are not high enough. Because typically you want your fees to be 2.5, 3 times Medicare. And if they're only like, 1 times Medicare or double what Medicare pays you, then you could be at risk of not getting full payment from some of your commercial payers. So you do want to see consistency there. And you do want to see things like trending in the right direction. Part of what I would also recommend is to set and track goals. So we talked about KPIs, how to calculate them, good ways to track them over time versus a 6-month summary. What is this reflective of in the revenue cycle? But then I think it's important, if you do have a staff of billers, in order to keep them motivated, is to set and track goals. And you can assign bonuses to this, incentives of some sort, So the way it works, and this is the way we do it, you say, okay, well, what is an average? So you may have to go to an MGMA, go to your clearinghouse, go to your vendor and say, well, what is the industry standard for my specialty for rejection rate or average days to bill of these? And that's what you put the first column. And then you say, well, what was our actual number? What did we do? And then you compare that. Well, how do we stack up to the average? Were we better than the average? Were we average? Or were we worse than the average? And then from there, you'll set your goals. And if it's an annual goal, which is what we would recommend, you can break it down into monthly and quarterly and track your progress. So in this example, we've got average days to bill. At the end of the year, we ended at our average days was 9. And we know the industry average is 10 to 14 days, so we're beating that. But we do want it to be more, if we can, get it less than 8, which is the best practices benchmark. So we've given ourselves that as the goal to hit by the end of the year. Same thing with the EDI rejection rate. We're at 5%. Our goal is to get it less than 4. Part of what you're trying to do here as well is to make it attainable. So, which is why you want to see what does a national average look like, and then what is our actual number. So if your actual number for days in AR, for example, is 70, it may not be feasible to get it less than 40 in a certain amount of time. And if you set it too far out of reach, your staff may not try as hard for it because they feel like, okay, this is not a winnable situation. You always want to put them within reach, but also, and this is why it can be hard sometimes to find that right goal, but you want it to make it not too easy either for them to hit. And if you start tracking it every month, you can say, well, are we getting closer to hitting the benchmark? Or are we moving further away from it, our benchmark? And if you're moving further away, of course, again, you're digging in, you're running those KPIs that we looked at earlier, looking for root causes. You're trying to find, well, if it's the AR that's getting further away, I'm going to run my AR and look at my numbers like we just compared and say, well, what's happening? Is it a certain payer? Is it my aging staff not getting to it fast enough? What is it? And then that's kind of how this works. You're focusing on incremental improvement. So as long as you're close, and then you're meeting with the teams and we're looking at this together. And again, part of this too is you're deconstructing your processes. So if the numbers aren't where they need to be, you do want to be reconstructing the process that goes behind this, which again, going back to that was the intent of the first 2 in this series of enhancing your revenue cycles is what new processes can we implement? What things can we change? What resources do we need to make a correction here? And these allow you to track. I've already said this, but this allows you to track whether or not the new processes are actually effective or not. This also allows you to hang your hat if there is improvements. And you want to be able to show not just your word, like if you do have a boss or, a board or someone, you can actually show them the actual numbers. And this goes a long way to being able to do that. So the final page here is just some additional tools. HFMA, even though this is a hospital organization, they do have a map keys. This is free. It's a website. They have physician KPIs and hospital with calculations and the whole set. And I know MGMA is a big benchmarking data as well, that if you Google it, some of it's free, some of it you have to pay for. Those are 2 great resources for finding your national averages for benchmarking. And again, the AAPC E&M tool, these are links here. When we do put this on our website and you get access to these slides, you should be able to click on these. But if you Google AAPC, the E&M audit tool, you should be able to find the one I showed earlier where you can just hand plug in your own E&M numbers and see where you stand against national averages. But from there, I've wrapped it up a little bit early. Bart, I don't know, have we gotten any questions? Let me see him.
So apologies, it took a moment to get off of mute. No questions answered as of yet. But if anybody has any last minute questions.
Oh, I see some under the questions section, Bart. If you look down there, it says, will we be emailed the webinar afterwards? You see that?
Yeah. Bear with me. Yes, I do actually see that. And I apologize. It's not showing up on my
Well, could
system.
You answer that for the rest of them? The first one is, will we be emailed the webinar? Will we be able to send them the slides, for example?
Yeah. So great question, my friends. And yes, after this, tomorrow, probably mid-afternoon, we'll be sending out this webinar to everybody that signed up.
Okay, so the next question was, how do you get payments per visit? There's two ways. So you could take the payments for a time period and divide total visits, which could be your total number of encounters or claims. Encounters is probably best for the time period, and just do the math that way. There's also where you can call matched transactions. So you can, and this one's a little bit more calculated or more complicated, but you take for every visit, once you've flagged it as being paid in full, meaning like maybe you've gotten a partial payment, that one wouldn't be completely done yet. But anything that you have marked as a complete, it's paid in full, then you take the average of those. But the simple way of doing it is to say, let me take how much money I got during a certain time period and just divide number of visits. And then the next one was about getting the slides. We can. What analytics tool would you recommend? So Dashboard MD is the one that we use. There are others out there, so I won't just try to steer you towards Azalea and our analytics tool. But if you do go out and do a little bit of research, you will find the ones that are healthcare specific are the ones that you want. There are going to be some that have KPIs and analytics that are more like broad, they're industry wide, and they may want you to put in the calculations. So if you are out there looking for a tool, make sure it's healthcare specific and they already know what the calculations are for like days in AR, average days to bill. That's something that's just plugged in automatically, so you don't have to build that out yourself.
Let me jump in there for a quick second, Doug.
What's that?
I apologize. So when I send out, pardon me, friends, when I send out the recording of this webinar, I'll actually attach some information for Dashboard MD, one of our great products. And if you have any interest, there'll be just a little radio button there you can check, and we'll give you all a holler and kind of walk you through what Dashboard MD is and how it works.
Okay. The next question was, do you have any KPIs or best practices for how many FTEs you would need per $100,000 of AR? And that's actually a very good question. I'll have to answer it from the perspective of a billing company who does billing for many different clients. You could look at it per claim or you're saying per 100,000 of AR. And I think generally speaking, something between 6,000 to 7,000 per FTE. So if you divide 6,000 to 7,000 into 100,000, could be, it depends too on the number of the service being provided. If you're doing full end to end or something in between, but somewhere like 67,000 per FTE. And then if you do it per claim, again, this is from a billing organization, you want somewhere between 1,000 to 1,200 claims per FTE. So if you're filing 50,000 claims in a month, for example, divide that by 1,000 or by 1,100. It depends on your efficiency level and then that kind of thing. Those are two ways that I would recommend that. If you're an individual practice, it may be different because it all depends on if they're dedicated to RCM, or if they have, I know in many cases they might be doing other things besides RCM in the office, but those are two that I would recommend. What is gross collection rate and net collection rate from one of your slides? So one of them, the gross just looks at total payments for a time period divided into total charges, and it doesn't take into consideration anything else. So if you build out $100,000 worth of charges for a period of time, and on that money, say you only got 30,000 back, then that would be a 30% gross collection rate. That very well could be, though, that you set your fees at 3 times Medicare, for example. So that may be good. That's why you want to track it over time. You also want to be aware of what does your fee schedule look like in terms of like compared to Medicare. And the net would be, say, if I build out $100,000 in a certain time period, how much of that was a contractual obligation, meaning it was paid and processed as in network, but there was a contractual adjustment of $70, and then maybe they paid me the other 30. It basically is helping you identify, well, how much did I collect as a percent? And it's factoring in things that were just not paid at all. So like if something was fully denied and not paid, the net collection rate allows you to identify. And again, the perfect score on that one is going to be like 100%. But that's assuming you don't get any denials and that every claim pays at 100%, and that the only other thing that gets written off is a contractual adjustment. But in order to do that, you want to make sure that you're able to isolate a contractual adjustment in your software versus like an adjustment that you may use for something like maybe you got an untimely filing, or maybe something was not medically necessary and you can't roll it to the patient for whatever reason, you just have to write the whole charge off. That's not a contractual adjustment, and you want to be able to isolate the two. Let's see. As an Azalea customer, are these automated dashboard analytics within the report section, or how do we access the dashboard MD? So that's a good, I don't know, Bart, if you want to answer that. They're not, the analytics piece is not within the standard report section of Azalea. And Bart, if they wanted to see more about that, how would they go about doing
that? So great question. Dashboard MD is a separate product of ours that holds all of those reports. And again, I will send an email tomorrow, and if you are interested, please do not hesitate to click that little button, and we will reach out to you to kind of walk you through it. It's a super cheap product for all of the things that it gives you, and all the insights and benchmarks and KPIs and comparisons. But I will send that out tomorrow, and again, just click on that show me button, and we'll set it up for you.
Right. Here's a good one. How do you increase your charge rates? So is this just a rule of thumb, 2 or 3 times Medicare, or what's the best practice? So we do say 2 or 3 times Medicare. If you wanted to get a little bit more granular with it, we would say for like your office visits, your E&Ms, to do 2 to 2.5. And if you're doing a surgical procedure or an in-office procedure, to do 3 times Medicare. And you're doing that because it is our recommendation to have one set of fees for all of your payers. Medicare, for example, does not like it if you're going to bill them one rate and a commercial payer a separate rate. So if you are going to go that route and you have one set of fees for all of your insurance plans, you want to make sure that the fee is set high enough so you will have a commercial payer that may pay you double what Medicare pays, or 150% of what Medicare pays. And if your fees aren't set high enough, in most cases, the payer is not going to pay you more than what you bill. So if the Medicare allowable is like 100, and maybe you just set your fee at 100, but United Healthcare would pay you 150. If you only bill them for $100, they're only going to pay you 100, and you lose out on the 50. So that is kind of a best practice. And as far as like how you do it, in most systems, like, and I know in Azalea, you can export your entire fee schedule. You can also go to the CMS website, for example, and you can pull their reimbursement per CPT for your region. And so you could, if you want to do this once a year, is what I would recommend, compare what Medicare pays per CPT in your region to what your fee is. Is it, 2.5 or 3 times Medicare or not? Or you could just take that list from Medicare and just do a calculation and then just completely refresh your fees that way. And again, once a year is a good way to look at it. Another thing I would recommend is, if you can in your system, look at reimbursement per payer per CPT. So there's, in different systems, it may be called different things, but you could say, show me my 99213 would be a good one because it's very common. And get me on, and let me sort that report in Excel by payer. So you'll have all your blue shields stacked up, and you'll see like 70, 70, 70 per payer. But then you may see some that are like 100. And if you can compare that to your gross charge, then you can see, well, who pays me the most per? Because I know a lot of practices don't have your contractual, your contract handy, so you don't know what is the payer supposed to be paying me. But a way you can reverse engineer what your allowables are is to do an analysis of your own reimbursement. So after you've posted the payments in your system, run the analysis, put it in a spreadsheet, and sort it by payer per CPT, and see what the trends are. And then that will also help you make sure that your fees are set high enough. So if you see, in that example, if you see a payer is on average paying you exactly what you charge, that would be a red flag that your fee is not high enough. And the next question, for the one where I showed you the report that had the 6-month averages, does it include the current month? Seems like it would be the preceding 6 months. That's actually, I don't know. That is a pre-built report, and I would imagine it is the preceding 6 months, but I actually don't know that for sure. I'd have to ask the folks that built that report. That's a very good question. I do like your suggestion that it would be the preceding 6 months and not include the current. And then the next one, Bart, was how much is Dashboard MD cost? I don't know if you want to address that one now, or it's per provider.
Yeah, indeed, and just very transparently, right? I believe it's $60 per provider per month. Again, the insights, and that's relatively cheap if you've looked around, to be just very candid, at other providers. Some providers charge in excess of $1,500 a month for something very similar. It gives you a full boatload of analytical reporting, as well as the comparisons through CPTs, through actual physicians. It's incredibly insightful, and if you've not seen it, just take a gander at it, and hit that kind of reply button, and at least let us show it to you so you have a comparative analysis.
Okay, last couple of questions. One of them is an observation. This is a Lego ship in a bottle, and my 8-year-old son made it. And I asked him, "What do you want me? You want to put it in your room?" And he said, "Well, how about you put it in your background so that way everybody that you work with can see it?" So he's very proud of that. And I barely had to help him put it together, but that is cool. The other question, the real serious question, is what are the rules to having a fee schedule that is standard? So I talked earlier about that, and then it says specifically, can we charge more for personal injury cases, for example? The general, you can. The general rule of thumb, and then this is again with who you're billing for, for insurance, meaning like healthcare, commercial, government payer, is to have a set fee for your commercial, your government, your Medicaid payers, because in particular CMS does not like it if you are charging two different amounts. A commercial fee over here. Now your allowables, what you're going to get paid by the payer, is going to be different, and you do want to track that if you can, to see if you're getting paid correctly, or if you're getting underpaid by the payer, or if your fee schedule is not high enough. But you do want to have a standard fee for all of your insurance plans if you can. But if maybe you do have something with a personal injury where you're going to get a much higher rate, but you don't want that to increase your fees for your others, then you could separate those. Here's this last one, Bart. This one's for you. Somebody wants a quote. Jessica,
so is that for, my friend, is that for Dashboard MD or for the EMR PM revenue cycle piece?
I guess we can follow up with you, Jessica. And then the last question is, what systems do the reporting analytics work with? The ones I showed you work with Azalea. Dashboard MD was recently acquired, and they were incorporated in other systems out there. But since we acquired them, they are available to all the Azalea customers. I will tell you, however, and I tried to make it to where it wasn't just all Dashboard MD analytics. You could build it yourself, or there are many EHR systems out there that have really robust analytics reporting built into them. You may have to check with them. They may charge extra for it, or a lot of your front end KPIs can be found at the clearinghouse level. I have seen over the last 5 years, clearinghouses have really stepped up their reporting game. So if you don't have access to something like that right now, you could find a lot of KPIs from your clearinghouse.
And this is for Jessica. Jessica, I am going to reach out to you directly after this to facilitate that quote that you were looking for, and so that we can get that in your hands today.
My email is on the screen here, guys, and my cell phone. So if you have a follow-up question about anything at all, I don't mind. If you needed information about any of the slides, or a question about a KPI, or anything you want to ask that was not covered today, please feel free to email me, or you can even text me if you'd like. But I appreciate you guys very much, and y'all have a great rest of your day.
Thanks, everyone. Have a great day, and thank you for joining.